and welcome to Audio Medical Basics. Before we start, I would like to say that this is a reshoot because after I shot this one long time ago, I found out only some time later that there is so much background noise and the video wasn't clear, as I will show in this next clip. So I'll do the old clip for the beginning of the video and then we'll continue with a new shoot. Thank you so much for keeping up. Hello
and welcome to my Audio Medical Basics.
In the last 4 videos, we read from the Signs and Symptoms Handbook. We went alphabetically as the books goes. We spoke about the abdominal distension, abdominal mass, and now for the third entry in the book, the abdominal pain. So, abdominal pain. Abdominal pain usually results from a GI disorder, but it can be caused by a reproductive, genitourinary, musculoskeletal, or vascular disorder, drug use, or ingestion of toxins. At times, such pain signals life-threatening complications. Abdominal pain arises from the abdominopelvic viscera, the parietal peritoneum, or the capsules of the liver, kidney, or spleen. It may be acute or chronic, diffuse, or localized. Visceral pain develops slowly into a deep, dull, aching pain that's poorly localized in the epigastric, periumbilical, or lower mid-abdominal hypogastric region. In contrast, somatic pain, parietal or peritoneal, this somatic pain produces a sharp, more intense, and well-localized discomfort that rapidly follows the insult. Movement or coughing aggravates this pain. Pain may also be referred to the abdomen from another site with the same or similar nerve supply. This sharp, well-localized referred pain is felt in skin or deeper tissues and may coexist with skin hyperesthesia and muscle hyperalgesia. Mechanisms that produce abdominal pain include stretching or tension of the gut wall, traction on the peritoneum or mesentery, vigorous intestinal contraction, inflammation, ischemia, and sensory nerve irritation. So these were the mechanisms that produce abdominal pain. Emergency interventions. If the patient is experiencing sudden and severe abdominal pain, quickly take his vital signs and palpate pulses below the waist. Be alert for signs of hypovolemic shock, such as tachycardia and hypotension. Also obtain IV access. Emergency surgery may be required if the patient also has mottled skin below the waist and a pulsating epigastric mass or rebound tenderness and rigidity. Next, history and physical examination. If the patient has no life-threatening signs or symptoms, take his history. Ask him if he has had this type of pain before. Have him describe the pain. For example, dull, sharp, stabbing, or burning. Ask if anything relieves the pain or makes it worse. Ask the patient if the pain is constant or intermittent and when the pain began. Constant, steady abdominal pain suggests organ perforation, ischemia, or inflammation or blood in the peritoneal cavity. Intermittent, cramping abdominal pain suggests that the patient may have obstruction of a hollow organ. If pain is intermittent, find out the duration of a typical episode. In addition, ask the patient where the pain is located and if it radiates to other areas. Find out if movement, coughing, exertion, vomiting, eating, elimination, or walking worsens or relieves the pain. The patient may report abdominal pain as indigestion or gas pain. So have him describe it in detail. Ask the patient about substance abuse and any history of vascular, GI, or gastrourinary or reproductive disorders. Ask the female patient about the date of her last period, changes in her menstrual pattern, or dyspareunia. Ask the patient about appetite changes. Ask about the onset and frequency of nausea or vomiting. Find out about increased flatulence, constipation, diarrhea, and changes in stool consistency. When was the last bowel movement? Ask about urinary frequency, urgency, or pain. Is the urine cloudy or pink? Perform a physical examination. Take the patient's vital signs and assess skin turgor and mucous membranes. Inspect his abdomen for distension or visible peristaltic waves, and if indicated, measure his abdominal girth. Auscultate for bowel sounds and characterize their motility. Percuss all quadrants, noting the percussion sounds. Palpate the entire abdomen for masses, rigidity, and tenderness. Check for costovertebral angle tenderness, abdominal tenderness with guarding, and rebound tenderness. So, before we move to the medical causes, which inshallah will be in the next video, there is a table about abdominal pain, types, and locations. This table here that I'll be reciting quickly. The table mentions each affected organ and the type and location of the pain, the visceral pain, the parietal pain, and referred pain of the affected organ. So we'll start with the appendix. The affected organ is the appendix. The visceral pain is in the periumbilical area. The parietal pain is in the right lower quadrant. The referred pain is in the right lower quadrant. Then next affected organ, distal colon. The visceral pain is hypogastrium. The visceral pain is in the hypogastrium and left flank for descending colon. The parietal pain is over the affected area. The referred pain in the left lower quadrant and back, which is rare. Next affected organ, gallbladder. Visceral pain is in the middle epigastrium. Parietal pain is in the right upper quadrant. Referred pain is in the right subcapsular area. Next affected organ, ovaries, fallopian tubes, and uterus. The visceral pain is in the hypogastrium and groin. The parietal pain is over the affected area. The referred pain is in the inner thighs. Next affected organ is the pancreas. The visceral pain is in the middle epigastrium and left upper quadrant. The parietal pain is in the middle epigastrium and left upper quadrant in the pancreas, and referred pain in the back and left shoulder. Next affected organ is the proximal colon. The visceral pain in the periumbilical area and right flank for ascending colon. Parietal pain is over the affected area. Referred pain is in the right lower quadrant and back, which is rare. Next affected organ is small intestine. The visceral pain is in the periumbilical area. The parietal pain is over the affected site. And the referred pain is in the mid-back, which is rare. So that was the small intestine. Next affected organ is stomach. The visceral pain is in the middle epigastrium. The parietal pain is in the middle epigastrium and left upper quadrant. The referred pain is in the shoulders. Finally, affected organ, ureters, visceral pain, costovertebral angle, parietal pain, over affected site, and referred pain, groin, scrotum in men, labia in women, which is rare. Thank you very much. This is all for part 1 of the abdominal pain from the Signs and Symptoms book. And as I said, this is a reshoot, so you see a massive change on my desk. And in part 2, we'll continue with the medical causes. And also there is a part 3. And it's very long. There is a lot of causes for abdominal pain. it's many pages, so just show you so you can see why it took me 3 videos to finish this subject only. So see you all in part 2 and 3, which is made in the past, and I say hello from the future.